Mr. Chairman, ladies and gentlemen, thank you to hear my presentation about our study about non-invasive detection of patient ventilator disharmony with surface electromyographic activity. First, I have no conflict of interest to declare. As you know, mechanical ventilation can be done with two distinct modes. The first one is the control mode, which doesn't interact with the respiratory muscle of the patient. On the contrary to the control mode, there is the assist mode, when the muscle of the patient are unloaded by the ventilator, while respecting the spontaneous breathing of the patient. By doing so, it might prevent negative effect on respiratory muscle function, and then maybe reduce mechanical ventilation duration. But to work assist ventilation, we must to have a good adequation between patient's demand and ventilator assistance. If there is an inadequation between these two parts, the patient demand and the ventilator assistance, it can lead to disharmony. So, patient ventilator disharmony is a mismatch between ventilator, which is controlled by the clinician, and patient inspiratory drive. There is two distinct situations. The first one is under assistance, which can lead to dyspnea, and the second one is over assistance with an over distinction. So it's a large concept which includes patient's respiratory sensation like dyspnea or discomfort, and asynchronies observed on pressure and flow waveforms. To date, we can detect patient ventilator disharmony with the analysis of mechanical signals like pressure. It could be the pressure of the ventilator on the ventilator waveform, but the detection needs expertise. It could be the detection by esophageal pressure, which is reliable but invasive. So there is another possibility is to use electromyography. Diaphragm electromyography is known to be reliable, but surface electrodes or needle electrodes or esophageal electrodes are invasive. So maybe there is an alternative. There is a place for using extradiaphragmatic inspiratory muscle to detect patient ventilator disharmony. So there is three candidates. We choose to use scalene, parasternal intercostal, and LNAZ because these three muscles have an easy access. We know on healthy subjects in non-invasive ventilation that they are activated proportionally to inspiratory loading. They are correlated with respiratory sensation, and also they are related to inspiratory drive. So the objective of our study was to show a relation between EMG activities of these three muscles and level of ventilatory assistance, dyspnea and comfort, and ineffective effort prevalence. We include a patient intubated and ventilated in pressure support ventilation. They need no sedation for at least 12 hours, and the Ramsay score was under 3. We include 12 patients. They were studied around 3 days of mechanical ventilation before study. The population was 5 COPD patients, 2 acute cardiac failure, 3 pneumoniae, and 2 acute lung injury and septic shock. So the study protocol is 4 conditions. The first condition is an high pressure support to obtain 8 to 12 milliliters per kilogram. And in this high pressure support condition, we put 2 settings of the expiratory trigger. 5% is the low expiratory trigger and 30% is the high expiratory trigger. We do the same thing with the low pressure support to obtain 6 to 8 milliliters per kilogram of tidal volume, and we set low expiratory trigger and high expiratory trigger. So we have 4 10-minute periods which were analyzed. We measure mechanical signal to the endotracheal tube, pressure and flow. We record surface EMG of scalene, parasternal and alienazi. As you can see on the graph, on the slide, you can see that we obtain EMG average EMG, then we obtain root mean square, and we analyze the root mean square by doing the EMG maximum, which is the peak of the activity of the EMG, and EMG area under the curve. We also make some clinical measurement, like dyspnea with a visual analogic scale on comfort using ATIS score, and we also measure the prevalence of ineffective efforts. So here are our results. As you can see on the first column, there is a scalene muscle, and the second one is a parasternal muscle, and the third one alienazi. On the first line is EMG maximum, and EMG on the second line is EMG area under the curve. EMG are expressed by the maximum, the percentage of the maximum activity of the EMG. So first you can see that in low pressure support we have an higher EMG activity of the swim muscle than in high pressure support. You can see also that expiratory trigger seems to have a low impact of EMG activity. There is no significant differences between low expiratory trigger and high expiratory trigger with high pressure support and with low pressure support. If we look about dyspnea and comfort, you see that the dyspnea is increased with low pressure support, is higher in low pressure support than in high pressure support, and it was the same tendencies with ATIS score. When you see that the ATIS score decrease, which mark an uncomfort, it decreases with low pressure support also. If we make correlation between dyspnea and EMG activity, we see that we found a strong correlation between EMG activity of the swim muscles and dyspnea. To look ineffective effort prevalence, we found ineffective effort only on the 5 COPD patients. As previously shown, prevalence of ineffective effort was higher during high pressure support conditions than in low pressure support conditions. And we found an inverse correlation between dyspnea and ineffective effort prevalence. Of course, we have to note that it's only 5 patients, so it's a correlation on only 5 patients. So to conclude, we can say that decreasing the level of assistance is associated with an increase of EMG activity. We found a significant correlation between EMG of these swim muscles and dyspnea. And in COPD patients, on 5 COPD patients, we found that the prevalence of ineffective effort seems to be inversely correlated with EMG activity and dyspnea. So, surface EMG activity provides a simple, reliable, and non-invasive indicator of respiratory muscle unloading. It could be a monitoring tool in patients in whom detection and quantification of dyspnea is complex. Of course, we need further clinical studies to validate this, maybe this new tool. Thank you for your attention.